Last time I read from the article, After DSM-5, a critical mental health research agenda for the 21st century. In the article, Jeffrey Lacoste, the author, through a series of conjectures, neatly sums up and advocates for independent research into the problems surrounding the Diagnostic and Statistical Manual of Mental Disorders. With so much money at stake, I questioned whether such research would ever be conducted or be taken seriously by the mental health industry. But now I want to look at an example diagnosis, Major Depressive Disorder, and its symptomatic criteria. But I want to first contextualize this diagnosis and criteria by looking at the debate surrounding the Bereavement Exclusion, which was first introduced in the DSM-3, but was eliminated in the DSM-5. To that end, let me jump in and read from the article, Validity of the Bereavement Exclusion to Major Depression. Does the empirical evidence support the proposal to eliminate the exclusion in DSM-5, published in World Psychiatry in 2012, written by Jerome C. Wakefield and Michael B. First, both from a number of psychiatric institutions in New York. The DSM-5 Mood Disorders Workgroup has proposed eliminating in DSM-5 the Major Depression Criterion E, Bereavement Exclusion BE, which recognizes that depressive symptoms are sometimes normal in recently bereaved individuals. This proposal has become one of the more contentious issues regarding the DSM-4 revision. Those favoring the BE's elimination argue that the empirical evidence demonstrates the BE's invalidity and supports its removal. For example, Zizook et al., reviewing studies that bear on the validity of the bereavement exclusion, conclude that the preponderance of available data suggests that excluding recently bereaved individuals from the diagnosis of MDE, that's Major Depressive Episode, may no longer be justified. And Lam et al. Assert that, since Zizook et al.'s review, 4 other studies have been published that provide further evidence supporting the removal of the bereavement exclusion. In this review, we examine whether these claims are justified. We evaluate the quality of the evidence put forward in the cited reviews, and also examine some more recent evidence bearing on the validity of the BE. Based on our results, we offer some recommendations for DSM-5. Prospective studies of bereavement have demonstrated what physicians have long known, that normal grief frequently includes depressive symptoms such as sadness, difficulty sleeping, decreased appetite, fatigue, diminished interest or pleasure in usual activities, and difficulty concentrating on usual tasks. A considerable number of individuals reach the 5 symptoms for 2 weeks level that satisfies diagnostic criteria for major depressive disorder, MDD. And many experience clinical significant distress or role impairment due to their grief. And I will get into some of the terminology differences and specifics in the DSM, but the debate here is important as it highlights how diagnoses are viewed by mental health professionals. Yet their bereavement-related depression may resolve over time without treatment and may not have the chronic and recurrent course seen in MDD. The overlap of symptoms between intense normal grief and MDD creates a potential false positive problem in which depressions that are part of normal bereavement may be misdiagnosed as MDD. Excluding all bereavement-related depressions from MDD diagnosis is no solution. Severe emotional stressors such as bereavement can trigger genuine MDD. Consequently, the diagnostic challenge is to distinguish those bereavement-related depressions that are likely intense normal grief from those that have turned into pathological depressions. The BE, which has been in the DSM in varying forms since 1980, offers the clinician guidance in making this difficult discrimination. It excludes bereavement-related depressions from MDD diagnosis only when they are uncomplicated. That is, they manifest certain duration and symptom features more consistent with normal grief than with mental disorder. If the depressive episode either lasts longer than 2 months or includes at least one of a series of features that are uncharacteristic of normal grief, that is, marked functional impairment, morbid preoccupation with worthlessness, and it is sad I have to worry about being censored for merely saying the words here that are directly in the DSM and in this paper, but I do not want my content taken down. A certain ideation, or rather thinking about passing away in a certain manner, psychotic symptoms, or psychomotor issues. And yes, this word is still used in relation to DSM diagnosis. If a depressive episode includes these issues the authors highlight, then the episode should be diagnosed as MDD. Conversely, if the episode resolves within 2 months and does not include any of the uncharacteristic features, then it is consistent with normal grief and is excluded from the MDD diagnosis. And this distinction is critical here. The rationale section on the DSM-5 website's Major Depressive Episode page explains that the reason for eliminating the BE is that evidence does not support separation of loss of loved one from other stressors. The website cites only one reference as the basis for this proposal, a review paper by Zizook and Kindler, that claims that bereavement-related depressions are generally similar to standard depression. Zizook and Kindler ask, is bereavement-related depression the same or different from standard, non-bereavement-related major depression? To answer this question, they compared bereavement-related depression to standard major depression following other triggers or no triggers. They evaluated whether the two conditions are similar or different on a variety of variables divided into antecedent, concurrent, and predictive validators, including demographic variables, family and past personal history of major depression, health and social support, associated clinical features, biological factors, persistence, and response to treatment, and claim they are similar on most validators. Similarity was not precisely defined, but seemed to be understood as having significant relationships to a variable in the same direction. Given that the bulk of standard major depression is clearly disordered, if a bereavement-related depression and standard major depression share enough validators, this was taken to imply they are likely the same pathological condition. In other words, the thinking from Zizook and Kindler is, if bereavement-related depression looks the same as pathological depression, as defined by Major Depressive Disorder in the DSM, then bereavement-related depression should also be considered a pathological condition. However, in terms of assessing the BE's validity, there is a fatal flaw to this review. Comparing all bereavement-related depressions to all standard major depressions has little to do with the evaluation of the BE. The point of the BE is to distinguish between excluded, uncomplicated, likely normal bereavement-related depressions versus non-excluded, likely disordered ones. The BE implies at most only that excluded bereavement-related depression is different from standard major depression. The BE declares non-excluded bereavement-related depression to be pathological. Combining the two bereavement-related depression groups and finding similarity to standard major depression does not test the BE. Zizook and Kindler acknowledge the problem. They note that an evaluation of the BE must distinguish between those who are considered by the DSM-4 text revision to be experiencing normal bereavement and those whose symptoms are so severe or persistent that the DSM-4 TR recommends considering the diagnosis of a true major depressive episode rather than just normal bereavement, and that their review largely fails to meet this requirement. In comparing all bereavement-related depressions, most of which the BE labels MDD and not normal grief, to standard major depressions, it is hardly surprising that Zizook and Kindler find similarity across a range of validators. A subsequent review attempted to overcome these difficulties and to specifically evaluate the validity of the BE. Zizook et al. Acknowledged the weakness of their earlier review, focusing on its failure to observe the BE's duration requirement. Zizook et al. Cite no new evidence and conduct the same type of similarity analysis, using the same variables as in the earlier review. However, they attempt to fix the problem with the earlier review by focusing on studies of depressive syndromes evaluated during the first 2 months of bereavement, referred to here as early-phase bereavement-related depression, which they consider directly relevant to assessment of the BE. Finding many similar relationships to validators, they conclude that the BE is not valid because, using validated criteria, bereavement-related depression within the first 2 months after the death of a loved one resembles non-bereavement-related depression. Despite the author's claims to the contrary, in fact, the Zizook et al. Review offers no more support for the BE's invalidity than did the earlier one. Throughout the paper, from the title, validity of the bereavement exclusion criterion for major depressive episode to the conclusion. The paper is framed as though it is reviewing studies pertinent to the BE's validity. A careful examination, however, reveals that not one of the cited studies actually examined cases that satisfy the BE. The BE's duration limitation that excludes episodes which end by less than or equal to 2 months, and its requirement that excluded episodes lack the 3 uncharacteristic symptoms are its core features. Yet not one study cited by Zizook et al. Applies either the duration or symptom requirements to the studied group. Consequently, they too examined mixed groups of BE excluded and mostly non-excluded bereavement-related depressions. Again, it is unsurprising that correlations with validators are in the same direction as standard major depression. The other core BE requirement for exclusion is that the episode does not include the so-called uncharacteristic symptoms, namely a form of ideation, wanting to pass away in a certain manner, a sense of worthlessness, or psychomotor issues. The Zizook et al. Review completely ignores this component of the BE criterion, taking the duration requirement in the mistaken form considered above as an adequate approximation to the BE. In sum, although Zizook et al. Claim to establish the invalidity of the BE, not one of the studies they cite applied the BE's duration or symptom criteria. The reviewed articles are essentially irrelevant to claims about the BE's validity. So in short, at least from the perspective of Wakefield and First, the whole dispute surrounding the removal of the bereavement exclusion for MDD revolves around and hinges on the serious qualification of that same bereavement exclusion. In other words, they make it clear that not just anyone who is bereaved should be excluded from a diagnosis of MDD, and in turn, Wakefield and First harp on even further qualifications to the exclusion as a potential correction moving forward. Past history of MDD as a criterion disqualifying exclusion. In guiding the provisional judgment whether bereavement-related depression symptoms are better explained as MDD or normal grief, an improvement in BE criteria that would protect against missing genuine cases would be to incorporate into the criteria the requirement that past history of MDD disqualifies a bereavement-related depression for exclusion. Individuals with a past MDD history have a vulnerability to developing MDD that might easily be activated under the severe stress of experiencing the loss of a loved one. The literature suggests that, among those experiencing an early-phase bereavement-related depression, past MDD history strongly predicts persistent, severe symptoms and non-excludability. This variable is impactful enough that research reports often separate outcomes according to past history. So instead of removing the bereavement exclusion entirely, Wakefield and First instead argue for including even more qualifications for the bereavement exclusion, which had already been restricted to uncomplicated bereavement to begin with. In other words, from Wakefield and First perspective, it would seem the only context that should be included in the DSM, excluding anyone who reaches the 5 symptoms for 2 weeks criterion for MDD from being given a diagnosis, is a narrow definition of bereavement. But of course, the alternative won out and the bereavement exclusion was removed entirely. And I will stop here. But next time I will dig directly into the DSM, working my way to the 5 symptoms for 2 weeks criterion that supposedly defines pathological depression or MDD. I hope to see you there.